everyone, welcome to SKMed Concept. So today we are actually going to discuss some of the questions from Croak 1 pharmacology base. Okay, so the first question is like a child suffers from drug idiosyncrasy. What is the cause of this reaction? So before moving on to the options, I want you to remember some of the terms like drug idiosyncrasy, accumulation, tolerance, tachyphylaxis and anaphylactic shock. So drug idiosyncrasy means it is actually related to some genetically abnormal reactions. So what exactly happens is if the patient is lacking some enzymes, okay, genetically lacking some enzymes, then only that particular person will show some abnormal reaction to a particular drug. So we can say that drug idiosyncrasy is a genetically determined abnormal reaction to drug. Then comes accumulation. Accumulation is equal to accumulation. Accumulation means there are actually two types accumulation. So it can be material accumulation or it can be functional accumulation. So material accumulation is seen in case when there is accumulation of drugs, and when there is accumulation or accumulation of drug effects, it is known as functional accumulation. Then comes tolerance. Tolerance is actually as the name states, it is a decrease in drug reaction. So it happens due to repeated administrations. When drug is given again and again and again, the drug action or the effect of drug will decrease. And tachyphylaxis. Tachyphylaxis is same as tolerance, but then it is a sudden tolerance. It can be shown from the first day of treatment or it can be shown from the second day of treatment immediately. Just like the patient may be showing a positive reaction to the medicine or to the drug only on the first day, and from second day the patient is not responding to medicine. So this is tachyphylaxis. And then comes anaphylactic shock. So anaphylactic shock, as we all know, it is a type 1 hypersensitivity reaction. So the drug which we are giving in may act like an antigen and our body will produce antibodies and resulting in hypersensitivity. So now let's go back to our question. A child suffers from drug idiosyncrasy. What is the cause of this reaction? So option 1, accumulation of pharmaceutical substance. No, accumulation is accumulation, right? And then inhibition of microsomal liver enzymes. No, there is no connection with inhibition of enzymes. And then third, hereditary enzymopathy. Fourth, exhaustion of substrate. Fifth, associated disease of target organ. So now we already know that drug idiosyncrasy is something which is a genetically determined abnormal reaction. So the answer is hereditary enzymopathy. Now moving on, a patient suffering from myasthenia has been administered Proserin. After its administration, the patient has got nausea, diarrhea, twitch of tongue and skeletal muscles. What drug would help to eliminate the intoxication? Okay, so before going on, you have to have a basic idea about Proserin. Proserin, what is its mechanism of action and why is it used in case of myasthenia? So Proserin, or the other name is neostigmine. Okay, so this is an anticholinesterase drug, and the function of this drug is to inhibit the activity of acetylcholinesterase enzyme. So where can you find this acetylcholinesterase enzyme? Usually when acetylcholine is accumulated in neuromuscular junction, this enzyme helps in the breakdown of acetylcholine into acetate and choline. So now why are we giving this in case of myasthenia? Because once we prevent this enzyme, okay, so we are stopping this enzyme. So what happens? The breakdown of acetylcholine is not taking place. So because of this, acetylcholine concentration will increase in neuromuscular junction. So when patients are suffering from myasthenia, this is very useful in such patients because the acetylcholine concentration in neuromuscular junction is increased. So because of that, their muscle power will be increased. But here the question is, they have given Proserin, but what happened is the patient is intoxicated. Okay, there is a more dose. Maybe because of more dose, the patient has more concentration of Proserin body. So now we have to give something which will remove the effects. So now let's see the options. Physostigmine. Physostigmine is an anticholinesterase drug, and also you have to remember some more anticholinesterase drugs like galantamine, pyridostigmine, bromide. All these are anticholinesterase. Then ephedrine. Ephedrine is a beta adenomimetics. So they are actually stimulating beta 1 and beta 2 receptors, which is of no use here. Then Macetone. Macetone is again an alpha adrenomimetic which will stimulate alpha 1 receptors. This is not what we need here. We actually need something which will decrease the concentration of acetylcholine in neuromuscular junction. So the best one will be something drug which falls in M-cholinergic blocker. So from the options you know that atropine sulfate is an M-cholinergic blocker. So what they do, they will bind to M receptors and then they will prevent the binding of acetylcholine in neuromuscular junction. So when this action is prevented, definitely there is a decrease in the concentration of acetylcholine in neuromuscular junction, and then this can be used to relieve the patient from intoxication of proserine. So always keep in mind atropine as an M-cholinergic blocker. It can be used for treating anti-acetylcholine esterase poisoning, cholinomimetic poisoning, and as well as mushroom poisoning. These 3 points are very important for CROC. Then moving on, a patient with frequent attacks of stenocardia was prescribed Suxtec forte to be taken 1 tablet twice a day. At first the effect was positive, but from the second day stenocardia attacks resumed. What is the reason for this inefficacy? Again, already in the first question I already mentioned that tolerance and tachyphylaxis. Tolerance is a decreased drug reaction due to repeated administrations, but then tachyphylaxis is a sudden tolerance due to like if they are suddenly giving the drug, patient shows positive reaction on the first day and the second day the patient is not responding. So let's see the options. Idiosyncrasy, we learned it is an abnormally genetically determined reaction to drug. Dependence is something the patient is depending on medicine. It's like an addiction, because the patient is depending on medicine even if they are removed from the prescription. Okay. Accumulation is accumulation. Sensibilization is something the patient is sensitive to drug. This is not a case of sensitive. This is actually the patient is not responding. So the best option is tachyphylaxis because it is a sudden tolerance reaction. Then moving on. A 12-year-old child has intolerance to some foodstuffs. Their consumption causes an allergic reaction in form of itching, skin eruptions. What antihistamine drug should be administered so that the child could attend school? Okay, so here there are 2 things you have to keep in mind in such questions. First of all, you have to prescribe an antihistamine drug. Okay, that's an easy part. But the second thing, they also mentioned that we should prescribe something so that it will not affect the academic life of child, so that the child could attend school. So that means we have to give something which will not make the child sleepy in class, right? So let's see more into that. So you know that antihistamines are inhibiting H1 receptors, right? So these antihistamines are of 2 generations or 2 classes, like first generation and second generation. So first generation antihistamines, they penetrate blood-brain barrier and they will result in sedation. So you can say that first generation antihistamines are causing sleepiness. Therefore, they are contraindicated in people who are requiring constant attention. We can say drivers, or we can say railway workers. Railway workers questions are also there in CROC. That means in people who are requiring attention, we don't give first generation antihistamines because they cause sedation by crossing blood-brain barrier. Then second generation antihistamines do not cause sedation, therefore it is preferred in people who is requiring constant attention. So now let's see the options out here. Ephedrine is an adrenomimetic. Okay, it is an adrenomimetic. We need an antihistamine. In the question it is clearly mentioned we need an antihistamine. So ephedrine is an adrenomimetic, and diclofenac is again an NSAID. Aminophylline is a bronchodilator, and dimidrol and loratadine. This is the options we have to look for. So dimidrol is also an antihistamine and loratadine is also antihistamine. But the issue comes which is the first generation and which is the second generation. So dimidrol is the antihistamine which belongs to first generation, and loratadine is antihistamine which belongs to second generation. In coming slides, actually I have put up a table which will help you to determine a very few common first generation and second generation antihistamine drugs. So I hope this is clear. Moving on, the alternate usage of dichlorothiazide, ethacronic acid, and Lasix didn't cause marked diuretic effect in patient with marked peripheral edema. So increased amount of aldosterone is in the blood, indicate the medicine to be prescribed. So firstly, patient is having peripheral edema, and also dichlorothiazides were given, ethacronic and Lasix is another name for furosemide. All these were given, but then the patient is not curing. And there is one more clue given in the question, that there is increased amount of aldosterone in the blood. So it means that we have to give a kind of diuretic which is aldosterone antagonist, because all others are not working and there is increased aldosterone in blood. So now let's see. Again, clopamide is a thiazide like diuretic, so it will act on sodium chloride transporter and increase NaCl excretion. Then mannitol and urea, we already know that they are osmotic diuretics which have water absorbing property. Then amiloride is potassium sparing diuretic with epithelial sodium channel blocking action. So we already know that even in my lectures on diuretics, I mentioned that there is a video saying about potassium sparing diuretics. They are of two types: epithelial sodium channel blockers and aldosterone antagonist. Then spirolactone is also potassium sparing diuretic, but they actually belong to aldosterone antagonist group. And one of the most important side effect of spironolactone which you have to keep in mind is gynecomastia. So again, the question is very much clear, I hope. Moving on. An elderly patient has chronic constipations induced by large intestine hypertonia. What drug should be administered? Okay, so let's begin with from the last. Novocainamide or novocainoprocaine is the same name. So we know that they are local anesthetic drug. So local anesthetic drug and chronic constipation, there is no relation. Castor oil is actually a natural laxative. Even in most of the villages it's given to patients, but then the thing you have to keep in mind is it is contraindicated in chronic constipations. It should be never given in case of chronic constipations. Then sodium sulfate. Sodium sulfate is an electrolyte repletioner, right? Electrolytes. When there is an excessive vomiting or diarrhea, this is an electrolyte repletioner. Then atropinus M-choline blocker. Then comes bisacodyl. Bisacodyl is a laxative drug. So the function of laxative drug is obviously to induce diarrhea, right? So diarrhea and clean colon. So the main indication for bisacodyl or laxative drug is chronic constipation. So we can say that in chronic constipations, bisacodyl is the best option. Moving on. A patient in post-operative period was prescribed an anticholinesterase drug for stimulation of intestinal peristalsis and tonus of urinary bladder. So what drug is that? Okay, now let's start with dichlorothiazide. So we know that it is a thiazide diuretics. Reserpine is actually an adreno blocker, which is even indirectly acting adreno blocker. So we need something. It's already mentioned that the patient was prescribed an anticholinesterase drug. Okay, so we have to search for the anticholinesterase drug. Then mannitol is an osmotic diuretic. Propranolol is a beta blocker. And then comes our proserine. So already we discussed that proserine is an anticholinesterase drug which will block the activity of acetylcholinesterase enzyme. So there also you have to keep in mind the main indications of proserine. Myasthenia gravis, paralytic ileus. That means the same thing. Intestinal peristalsis is reduced in such cases. And then atonia of urinary bladder. Proserine is the best choice. So I think most of the questions, if you are having an idea about the drug class and mechanism of action, it's very easy to answer most of the questions in pharmacology. Then moving on, an ophthalmologist used 1% macetone solution for the diagnostic purpose. So why do they use macetone? For pupil dilation. Okay, so what is the cause of mydriasis? Mydriasis means pupil dilation induced by the drug. So again the question is clearly mentioning the drug used is macetone. So we know that macetone is an alpha adrenomimetic. So they will stimulate alpha 1 receptors. Okay. So obviously we know that it is a stimulation of alpha 1 receptors. But some points you have to keep in mind. I shall give a rough idea about the adrenoreceptors. So adrenoreceptors are like alpha receptors and beta receptors, right? So the function of alpha 1 is to constrict blood vessels and cause and also cause mydriasis. And alpha 2 receptors are, it's almost similar to alpha 1 receptors. They are actually mimicking the alpha 1 receptors. And when it comes to beta side, beta 1 will increase heart rate, beta 2 will dilate blood vessels, decrease GIT secretion, relax urinary bladder, and also cause bronchodilation. And beta 3 is for lipolysis. So keep in mind, alpha 1 receptors will constrict blood vessels, beta 2 receptors will dilate blood vessels, and alpha 1 is responsible for mydriasis. So now I hope this portion is very much clear. Always have a basic idea on these receptors: alpha 1, beta 1, alpha 2, beta 3, M1, M2, M3. All these receptors, it's best if you keep a note saying what are the main actions they do. Moving on, a student came to see a doctor and asked to administer him a drug for the treatment of allergic rhinitis that occurs in the period of linden flowering. What drug may be used? Okay, so we know that allergies are due to the stimulation of histamine receptors, right? So in case of allergies, so what is the drug of choice? Obviously it will be antihistamines. So now let's see which is antihistamine in this options. Ambroxol. Ambroxol is a mucolytics. They actually increase the production of serofexatine. This ambroxol topics is already there in video. You can check it out. And propranolol is a beta blocker. Losartan is angiotensin 2 receptor inhibitor. And what is left? Noradrenaline is again adrenomimetic. So it is already, we are very much clear that we need to find out antihistamine, right? And the last option which is supporting our question is loratadine, because loratadine is a second generation antihistamine. Then next question, a patient diagnosed with a morphism has been admitted to a narcological department. A doctor noted a decrease in pharmacological activity of morphine. Repeated use of a drug may result in tolerance to effect and this phenomena. Okay, so here the question is like the patient has been diagnosed with excessive use of morphine. So also there is a repeated use of drug. So this repeated use of drug resulted in tolerance, but then the patient has been found using again and again. That is why he is now poisoned with morphine. Okay, he is found with morphinism. So obviously we know that tachyphylaxis is a sudden tolerance reaction to drug. So it is not that. Antagonism is when two drugs are acting oppositely, or when we are taking just one single drug, even their functions are happening opposite to what we expected or what is meant. Allergy, not allergy, and accumulation, we know it is functional or material accumulation. So the best option is addiction, because addiction is something which happens due to repeated use of drug. So this repeated use of drug will lead to tolerance. So it's addiction. Moving on, a patient with a limb fracture must be administered a depolarizing drug from the myorelaxin group for the purpose of a short time surgery. What drug is that? Okay, so here we have to find out a depolarizing drug, and that too depolarizing myorelaxant. So again, let's see from the behind, from the last option. Atropine sulfate is an M-choline blocker. Pendamin is a ganglion-blocking agent, and cytotonin is a cholinomimetics. Here comes tubocurarine and dithium. So why I am stressing tubocurarine and dithium? Because these are the main myorelaxants you have to keep in mind. At least for CROC, you have to remember dithium and tubocurarine chloride. So tubocurarine is a myorelaxant, but it is a non-depolarizing myorelaxant, because myorelaxants are of two types: depolarizing and non-depolarizing myorelaxant. So tubocurarine is a myorelaxant but of non-depolarizing myorelaxant, and even some other non-depolarizing myorelaxants are like atracurine, pancurine. So what is their function is they will bind with N receptors and they prevent acetylcholine binding. So whenever there is a tuberculin chloride poisoning, that means whenever there is a non-depolarizing myorelaxant poisoning, the antidote is atropine plus neostigmine. But whenever there is a poisoning with depolarizing myorelaxant, the only antidote is a fresh blood transfusion. This is a very important point you have to keep in mind. Don't confuse with the antidotes of non-depolarizing myorelaxant and depolarizing myorelaxants. So again, dithiolium, when it comes to dithiolium, we know that it is a depolarizing myorelaxant, and even succinylcholine is also a depolarizing myorelaxant. So what they do is they will react with receptors at muscle end plate. They will cause some depolarization, and then they will cause a short-term surgical requirements. That means short-term paralysis of muscles. Always keep in mind the antidote. So I hope this is very clear. Always keep in mind myorelaxants are of two types, depolarizing and non-depolarizing, and tuberculin and dithiolium is something you have to remember. Okay, then the next question, a patient with, okay, this is a table I already mentioned in some of the slides. A patient with insomnia induced by allergic reaction and which has been prescribed the drug that has antihistamine and hypnotic effect. Okay, so here a patient has been already prescribed with an antihistamine drug which is having hypnotic effect, that means which is having sedative effect. So we already know that first generation drugs, antihistamine drugs, are causing sedation. So now let's find out the drug. Analgin is a painkiller. Acetylsalicylic acid, the other name is aspirin. Aspirin is a non-steroidal anti-inflammatory drug. Prednisol is corticosteroid. Loratadine, we already learned that it is a second generation antihistamine which it does not have any hypnotic effect or which doesn't cause any sedation. And then Benadryl. Benadryl is actually another name for diphenhydramine. So now you can check up the table here. This is a classification of antihistamines, first generation and second generation. So whatever marked, like even if you're not remembering all the things, just remember that first generation antihistamine drugs are like chlorpheniramine, diphenhydramine, or the other name is Benadryl, promethazine. And second generation are levocetirizine or cetirizine, loratadine or desloratadine. So at least try to remember these many antihistamine drugs belonging to each generation. So here the patient has been prescribed with hypnotic effect, so it is Benadryl. So that's all for today. We will see you in next video with more topics and more questions and more discussions. So thank you.